So this is a talk on dyspepsia. Just like the other lectures, this is going to be a stepwise approach, algorithmic approach for dyspepsia. Basically, we are looking at the NIC, National Institute of Clinical Excellence, NICE guidelines. Based on that, we will be discussing the topic, an algorithmic approach. So this is the NICE guidelines, dyspepsia management, dyspepsia in adults in primary care, 228 pages, monogram is there. Based on that monogram only, this talk is tailored. So we thank them for that. Think a while. Patient comes with dyspepsia. You think it is a very innocuous and non-dangerous condition. It could be GI malignancy also. So what am I dealing with? Is it upper GI cancer? Am I missing any elements? You have to question ourselves. Don't just write PPI and then send them away. You need to diagnose what is the dyspepsia and then only treat. For that, this stepwise approach will help you. Should I also look for H. pylori? Is it required in all the patients or only who? Which type of patients? Sometimes the dyspepsia may be drug induced. Patient may be taking NSAIDs or steroids or some other gastritis producing drugs. So if you stop the drug, the dyspepsia disappears. What is the modern management? The management has changed a lot from antacids. When we were students, there were no PPIs, there were no H2 blockers. None of these, there were no motility gas regulators. None of these drugs are available. All we had was a bottle of antacid, either powder or bottle. Neutrodona with belladonna, powder usually. That powder contains belladonna, which is antispasmodic, and some antacid powder. Dissolve that and ask the patient. This is all what we had. We have moved a long way from antacids. And now so 1900 to 2000, and now we are already 25 years into this century. 21st century dyspepsia is gastric cancer is decreasing, peptic ulcer is decreasing, functional dyspepsia is increasing, GERD is increasing, surgeons have lost jobs, those who are doing gastrojejunostomy and vagotomy, surgeries for peptic ulcer and gastric cancer. They have changed jobs because there's no need for any surgical intervention now for peptic ulcer or gastric ulcer. On the other hand, the newer diseases like AFD, functional dyspepsia, GERD, come. The 21st century dyspepsias are functional dyspepsia, FD, and GERD, they are on the increase. In 1900, nobody knew a diagnosis of functional dyspepsia. Not even when I am a student in 1970s and 80s. So we never knew and had a diagnosis of functional dyspepsia or GERD. At that time, gastric ulcer and then duodenal ulcer together called peptic ulcer. Of course, cancers were also there at that time. More of gastric and duodenal cancers, less of esophageal cancers. Today, the numbers have reversed. We have less of gastric cancers and more of esophageal cancers. Now, coming to what is dyspepsia? There must be clinical features of upper GI origin. So, there must be some clinical features which are suggesting upper GI disease. Yesterday, I had some heartburn. It's not dyspepsia. 4 weeks minimum, you have to have the symptoms. The patient has got more than 4 weeks duration, then it qualifies for dyspepsia. Otherwise, it is only you would have had some spicy or some oily food yesterday and you had little hot upset. That's okay. Pain induced or worsened by food. 40% in adults have lifetime dyspepsia, at least one episode. Generally benign, promote self-care. Today they go to the medical store and ask them, Ranitine Matra, please give. They will ask, Dentec, they themselves will take. Or antacid, they will buy. Symptoms are poor indicate predictors of problems. Patient doesn't have much symptoms, may be having gastro. Patient is very severe symptoms, may be functional dyspepsia. So symptoms and disease, they don't go parallel here in this disease. So employ a broader definition. Dyspepsia, as it appears, is not that a simpler disease, but it is more a sort of disease which has got so many small intrigues. Now, just like in any disease, the patient complains of dyspepsia. That means upper GI symptoms of 4 weeks duration or more. Then we should not miss dangerous conditions like gastric cancer. And there are certain alarm signs. So you have to identify the alarm sign and be careful about that. GI bleeding. Somebody comes with dyspepsia or GI bleed, same day it does. Don't wait. Progressive weight loss, unintentional weight loss, progressive weight loss. Sir, I have 75 kilos. No, last 6 months I lost about 15 kilos. Have upper GI disc. Maybe malignant. Progressive dysphagia, it's increasing. And then particularly dysphagia, difficulty in swallowing food, either liquids or solids. Persistent vomiting, iron deficiency, anemia. They touch the abdomen, there is a mass in the abdomen and dyspepsia. It is dangerous. Suspicious, nobody does barium meal today. Patient may be of any age. The elderly, always you keep these things in mind. So, mad blow, some sort of mnemonic I give. M mass, A anemia, D dysphagia, BL blood, either upper or lower, W weight loss. Mad blow. Keep that mad blow in mind. Again, M stands for mass, the epigastrium, A, iron deficiency anemia, or any other type of anemia. D for dysphagia, BL blood, upper or lower GI blood loss, and W is the weight. Persistent vomiting, you can add. So what is the difference between dyspepsia and reflux disorder? Dyspepsia is more an abdominal pain, bloating, nausea, early satiety. Sir, I used to take this much food, no problem. Now I eat little bit. I'm feeling my stomach is full. Early satiety, burping, and then borboring. It is intestines talking to him inside. Borboring. He feels the intestinal movement, burping also, frequent burping. This is dyspepsia. Burping, you know what is burping. Reflux disorder, there is acid regurgitation, and he feels a jet of acid coming into the throat, heartburn, epigastric pain, burping may be there, water brush. Suddenly the salivary glands will be ejecting a brush of water because of the reflux. And dysphagia. So slight difference in the symptomatology. That this is a study where they have analyzed people with simple dyspepsia. What are the various proportions? Gastric ulcer around 3%, duodenal ulcer 6.5%, gastric malignancy around 3%, gastritis 30%, GERD 24%, hiatus hernia 17%, no significant lesion, also called functional dyspepsia 17%. So, mean to say the common things are gastritis, GERD, FD. Gastritis, GERD, FD, phytosatia. Malignancy, though it is rare, should not be missed. Duodenal ulcer and gastric ulcer today are not seen very much because patients start on PPIs or H2 blockers on themselves. So the progression to an ulcer formation is not that very common. Now, you look at this diagram. Highly important to differentiate the dyspepsia into uninvestigated dyspepsia. This is based on the NICE guidelines I showed you, start with. A 248-page National Institute of Clinical Excellence UK guidelines. That book is the basis for this presentation. Very excellent monogram. UID, uninvestigated dyspepsia, GERD, gastroesophageal reflux disease, PUD, peptic ulcer disease, NUD, non-ulcer dyspepsia. PUD includes both gastric and duodenal, and FD, no lesion found, but patient has dyspepsia, functional dyspepsia. So these are the 5 various classes. When you ask patient with dyspepsia, you have to classify them what we are treating. Is it GERD? Is it PUD? Is it NUD? Is it FD? And of course, is it gastric malignancy? That we have removed. Gastric malignancy apart, the remaining things are UID, uninvestigated dyspepsia. We didn't do an endoscope and then demonstrate what is the diagnosis. But then uninvestigated way, empirically we treat. There is a room to treat empirically. You don't have to put endoscope for everyone. There is a protocol to empirically treat and if necessary test. Treat and test. Sometimes we test and treat. Treat and test, test and treat. Treat and test also is possible. In that case, you will have uninvestigated dyspepsia, treat for 4 to 6 weeks. The symptoms not resolved, you must go for endoscopy. 4 weeks minimum symptoms, dyspepsia qualified, examined, no alarm signs. That means no mad blow, no mass, no anemia, no dysphagia, no blood in the upper or lower GI tract, no weight loss, not elderly, young patient less than 55 years. You are qualified to treat him as uninvestigated dyspepsia. Treat for 4 weeks with proton pump inhibitors, and then maybe necessary 2 more weeks you give. And then if he's not responding, you have to do an endoscopy. Somebody is having bleeding, upper GI bleed, immediately, same day endoscopy. What are the other non-GI causes of dyspepsia? Various types of dyspepsia are UID, NUD, GERD, PUD, CA cancer, functional dyspepsia. Cardiac disease mimics upper abdominal pain, epigastric pain. COPD is also a confusing thing. And another thing is patients with COPD, they are more prone for dyspepsia. Liver and biliary disease might present like dyspepsia, polycystitis and gallstones. Pancreatic diseases and bowel diseases are also differential diagnosis. What are the various management options I have? Lifestyle measures, medical treatment, and then endoluminal therapy or surgery. Medical treatment resolves into PPIs, what agent I should choose, how long I have to give, H2RA receptors, that is the ranitidine group of drugs, how good they are, antibiotics, if you are suspecting H. pylori, prokinetics, when you are dealing with GERD and other motility disorders, alginates and antacids are self-care measures. Among these, the lifestyle measures are most often forgotten. The moment comes with dyspepsia, just 5 minutes you spend, Don't even examine, look for mass, look for anemia, look for weight loss. You forget doing all those things. Start writing, already proton pump inhibitor and send him away. And not tell him about lifestyle changes. He's not going to. What are the lifestyle measures? I require to. They play a very central role in lifestyle diseases. For example, a patient with Parkinsonism, what lifestyle disease things you will address? Mostly it is medical management or surgical management. Ask him to beware of falls. That's it. Other than that, there's nothing much that you need to change the lifestyle. Whereas here it is not like that. Most importantly, if the patient is a smoker, he must quit smoking. Avoid precipitants like coffee, chocolate, fatty food, and alcohol. Not spicy food. All spicy food is fat laden. That is why they get. This hurry curry hypothesis has gone. Don't. That doesn't mean that you should eat left and right spicy. The spicy food is shown in disease in studies to be not associated with ulcer formation or dyspepsia. But spicy food is always fatty. And sweet food also. A lot of sweets are made with fat, ghee or oil. Imagine any Indian sweet. It is made with fat oil. So fatty food is a precipitant. Smoking and weight reduction are very important measures, lifestyle measures. Somebody is obese, they have dyspepsia, they lose weight, the dyspepsia goes. So precipitants like coffee, chocolate, fatty foods, alcohol have to be most stopped. Then another thing is raising the bedded like this. The patient is sleeping like this. Put 2 pillows on the head and ask him to sleep as though he is sleeping in a reclining chair. Why? He is like this. What will happen? The acid in the stomach gravitates into the esophagus and produces a dyspepsia and GER disease. Also, ask him to lay on the left side a bit so that the stomach is on the left side and the liquids from the stomach cannot gravitate up. If he sleeps on the right side, the stomach contents gravitate into the esophagus. The position will be like this, slanting, little tilted to the left, with a pillow extra on this side, so that he is like that. I'm telling this because nobody advises this thing. I have not seen a physician who is talking to the patients about lifestyle in GERD. First thing is they write the prescription, ask them to go and take. Don't take hot food. Don't take spicy food. The only thing they know. Only that is not the answer at all. Smoking, weight reduction, alcohol, fatty food, and then chocolates should be avoided. Raise the head under the bed, left lateral position. Having main meal at least 2 hours before going to bed. For us, what is happening? Food and then bed. If possible, food on the bed. Food and bed. Immediately eat immediately. Should not be. And at least 2 hours. Why that 2 hours? Is to allow for the gastric emptying. So once you have the gastric emptying is over, then the reflux will not occur. Slowly reduce the PPIs and H2RES once they are responding. What are my goals of treatment? Goals of treatment are relieve pain, prevent complications, and minimize recurrence. What are the complications that can occur? Bleeding, perforation, obstruction. These are the 3 complications in a chronic case of dyspepsia. So bleeding may be there, upper GI bleeding, perforation may be there, the ulcer is there, and there could be an obstruction if there is a ulcer cicatrized, or it is due to the mass there, which is an important condition to diagnose. So relief of pain is of course important. Prevent complications is also important. And these complications are bleeding, perforation, and obstruction. So how do I go about? The first step is 4 weeks of upper abdominal symptoms like bloating, burping, burning, pain, vomiting, dysphagia, whatever are the upper abdominal symptoms. If you have a patient bleeding also, you have dyspepsia. First thing is, are there alarm signs or no alarms? It is a crime not to look for alarm signs because you will miss gastric cancer or esophageal cancer if you don't elicit the alarms. So what are the alarm signs? Already I have told you. Mad blow. M marks A anemia, D dysphagia, progressive dysphagia, BL blood in the upper or lower GI tract, and loss of weight. LO loss of weight. LOW loss. So these alarms and age, of course. So alarm signs have to be first elicited. The alarm signs are absent. Alarm signs are present. The alarm signs are present. You must go for upper GI endoscopy. There is no treatment called UID, empirical treatment is not there. Once somebody has got alarm signs, you must go for upper GI endoscopy. Or no alarms, but patient is more than 55 years, 4 weeks dyspepsia, you must go for upper GI. Anybody who has got alarm signs must get an upper GI endoscope. Anybody who has no alarm signs but is elderly, in the sense more than 55, you must go for upper GI endoscopy. Less than 55 are justified in treating, and if necessary, then testing. That is called empirical, uninvestigated dyspepsia treatment. So now we are going into the stepwise approach. I'm just covering the first step. So we have established a patient has got dyspepsia, 4 weeks of upper abdominal symptoms like burning, belching, burping, water brash, epigastric burning, epigastric pain, vomiting, dysphagia. Then he has already got 4 weeks of symptoms. Then first thing is alarm sign. Are there alarm signs present? Mass in the abdomen, per abdomen. A is for anemia. D is dysphagia. BL, blood in the upper or lower GI tract. And then loss of weight, LOW, loss of weight. If they are present, you must not delay endoscopy. Endoscopy should be asked immediately on the same day or next day or third day. But if there is bleeding on the same, the patient is having bleeding on the same day endoscope, other alarm signs, 2 to 3 days, finish the endoscopy. If there are no alarm signs, patient is does not have alarm signs. But what is the age of the patient? Is he more than 55 or less than 50? If less than 55, within 1 week, endoscope must be done. If more than 55, uninvestigated dyspepsia, empirical treatment is allowed. Okay. What is the second step? The second step is no alarm signs. Patient is less than 50. Then uninvestigated dyspepsia, empirically treat with PPI once a day for 4 weeks and then see. That is treat. Or you have got the option of test fire for H. pylori and then treat. Treat and test or test and treat. Either approach is accepted. Now you have the third step. Alarm signs are present or the patient is more than 55. Review all medications, suspend all NSAIDs and other ulcerogenic agents. Then order an upper GI endoscope and classify the dyspepsia and then start treatment. So how do I handle alarm signs or more than 55? Medication must be reviewed. Without reviewing medication, because they will be taking some medicines for the joint pain or some aspirin, some other medication which is oxygenic, you have to reduce the medication. Remember, 75 milligrams of aspirin is not going to produce dyspepsia. Somebody is taking 75 milligrams of aspirin for a cardiac reason. Don't attribute it as dyspepsia. It should be continued because the benefit of giving the aspirin is much more than stopping it. So order upper GI endoscopy and classify the dyspepsia. Upper GI endoscopy should be free from PPI and H2RA for at least 2 weeks before endoscopy. Usually before endoscopy, electively if you are doing, ask them to stop PPI or H2RA and then do the upper GI endoscopy. Supposing you are doing an emergency endoscopy, you need not wait for those two, except in emergency. NSAIDs and other oxygenic medications to be suspended for 2 weeks. All patients treated as undiagnosed dyspepsia should be referred for UGI if the patient is not responding in 4 to 6 weeks. The fourth step is UGI diagnosis system. What are the diagnoses possible? NUD, chronic gastritis, NUD is there, chronic gastritis is there, and then GERD is there, peptic ulcer or duodenal ulcer, and then gastric cancer. Treatment of uninvestigated dyspepsia. So I started a patient. Now here I am describing. He has got 4 weeks of dyspeptic symptoms. Does not qualify for endoscopy directly because he is not more than 55 and he does not have alarm signs. Then I treat him as uninvestigated dyspepsia. Medication and lifestyle. Lifestyle should not be forgotten. What is lifestyle? Dextromethorphan, smoking, coffee, chocolate, fatty food, time between sleep and the meal, position of sleeping, and then reducing the weight, and stopping the ulcerogenic or irritative medications. So medications, what I give now, full dose PPI for 1 month, followed by PPI or H2RA for 1 more month. If not responding, do endoscopy. This is the protocol. Uninvestigated dyspepsia. What is uninvestigated dyspepsia? I have already told. Lifestyle measures, medications, full PPI, followed by H2RA for 1 more month if not responding. And then, of course, you have got upper GI endoscopy has to be done with that. Now, non-ulcer dyspepsia. Supposing the endoscopist uses this one, no ulcer is there, but patient has got dyspepsia. It is called NUD, non-ulcer dyspepsia. Medication has to be thought of and lifestyle. In this patient, you have to test for H. pylori because you did an endoscope. You did not find any ulcer, but the patient is still having dyspepsia, or he may have changes of H. pylori. What is the endoscopic change of H. pylori? Have you ever seen H. pylori endoscope picture? What is the endoscope picture of H. pylori? There will be pan gastritis, diffuse gastritis will be there, salt and pepper appearance. Some red areas will be there, some white areas will be there. As I have sprinkled salt and pepper. Salt and pepper appearance and pan gastritis are the two important findings in H. pylori endoscopy. Anyway, we do a H. pylori test before, because we did an endoscope, we did not find typical changes. And there is a simple card test is there, like your hepatitis test from the endoscopic fluid. You can do the H. pylori test and treat it. Low dose PPI, H2RA for 1 month, No repeat endoscopy. For non-ulcer dyspepsia, there is no reason to repeat after 1 month or 2 months. Again, any non-ulcer dyspepsia, you don't have to repeat the endoscopy. Patient is persistent symptoms, low dose PPI, and leave him for self-care. Suppose patient continues to have symptoms, we have done our best. We have started him on the drugs. We did the endoscopy. Endoscopy did not reveal any cancer. There is no ulcer or anything there. H. pylori also tested. That is also negative. You give him persistent treatment on PPI and low dose PPI. That is once a day or half dose PPI. And also there is what is called PPI on demand. There is a new treatment called PPI on demand. Patient can take the PPI whenever he is having symptoms for a week or so and then stop. It does not have to continuously take. Now, you have to understand this GERD. What is GERD? Gastroesophageal reflux disease. As you can see here, this is the esophagus, lower end of esophagus. This is the stomach. There is what is called the gastroesophageal sphincter is there. Lower gastroesophageal sphincter. By lower, there is another sphincter in the upper area where so lower esophageal sphincter, and there is the acid in the stomach refluxes into the esophagus. That is called the gastroesophageal reflux. So this has to be sought out in the endoscope. Now, acid exposure in GERD. So GERD, this is called Savory-Miller grading. Stage 0, stage 1 and 2, stage 3 and 4. So if the pH is less than 4, that means acidic pH. Stage 0, only 4% of people will have. Stage 1 and 2, around 10% of people will have pH less than 4. Stage 3 and 4, up to 18% of people will have acidity in the stomach. So Savory-Miller grading is that one. So what are the extra esophageal manifestations of GERD? GERD, of course, how it presents, I have shown you. The upper GI pain, epigastric pain, retrosternal burning, particularly after taking food and lying down. They may have pain and dyspepsia also may be there. There may be burping, salivary brash may be there. So extraesophageal manifestations are persistent cough. I have treated n number of patients who came with persistent cough. They went from pillar to post to several doctors. They put them on antibiotics, cough mixture, bronchodilators, no relief. They come to us, evaluate properly, treat dyspepsia, cough is gone. We'll see persistent cough, several patients will come. Dyspepsia is not thought of. If the dyspepsia is treated, the cough. Then persistent cough, and common cause is ACE inhibitors, dyspepsia, COPD. Okay, posterior laryngitis, laryngeal stenosis, aspiration can occur, asthma may be precipitated, patients may have sinusitis also because of GERD. These are called the extra esophageal manifestations of GERD. So what are the complications that GERD can produce? One is esophagitis, the second one is peptic stricture of the esophagus, Barrett's esophagus, esophageal ulceration, upper GI bleed, and rarely adenocarcinoma. So GERD is not a simple disease. It can go into complications. The complications are esophagitis, peptic stricture, Barrett's esophagus. I'll show you a picture of Barrett's esophagus, esophageal ulceration, upper GI bleed, and adenocarcinoma. See, normally the stomach is lined by columnar. Esophagus is lined by squamous. Now, what happens is in Barrett's esophagus, there is a metaplasia of the lower esophageal mucosa from the squamous to the colon, because it assumes the same mucosal pattern of the stomach for the acid, because the columnar epithelium is there to have withstand the acid. As the squamous epithelium is not able to withstand the acid, there is a metaplasia that occurs, and columnar line distal esophagus, it starts happening. Normally it is squamous, now it becomes columnar line distal esophagus, and you can see endoscopically it is something like a very ruddy lower end of the esophagus. The hole that you are seeing there is the gastroesophageal opening there. This is called Barrett's esophagus, a precancerous condition. It can lead on to adenocarcinoma of the lower end of the esophagus. So what is the treatment of GERD? Now, lifestyle medications, full dose PPI for 2 months. This is one condition where you have to give full dose PPI at least for 2 months. And if it's not responding, then you give double dose PPI for 1 month, 1 more month, and add a prokinetic in addition to the PPI. Because it's the motility disorder, there is a role for the prokinetics. Then you reduce it to H2RAs or prokinetic for 1 more month. If there's no response, it is not GERD. Review the diagnosis. Maybe hiatus, maybe something else. GERD must respond. So what is the management? The management is like this. Lifestyle modifications and review all medications. Full dose PPI, proton pump inhibitor, esomeprazole or omeprazole or lansoprazole or etioprazole, whatever is the prozole you use for 2 months. Then double dose PPI for 1 more month. Prokinetics are added to the PPI. Then H2RAs and prokinetics for 1 more month. No response, review the diagnosis. And low dose maintenance treatment, return to self-care with antacids at the end. Now, you need to know a bit about H. pylori testing. H. pylori is a bacterial infection of the upper GI tract. Most of us who eat outside food, who don't take protected water, they will have H. pylori. It is like amoebiasis, it's like any other waterborne disease. This bacterium, once colonizes in the stomach, it can produce very severe abdominal pain and non-remitting. With PPIs, you have to test and treat. So I told you the appearance in the endoscope. There are 3 tests out there. One is called the urea breath test, UBT. The other one is called the fecal antigen test or gastric endoscopy antigen test. And serology, you have the IgM and IgG CAR test, ELISA IgM, you have to have. Now, between the 3 tests, UBT is the most accurate, costly, cannot be done in pregnancy because you use radio-labeled urea. It is not available everywhere. In this hospital also, we don't have UBT. We don't have. I tried to get one test done for one patient. We don't have. Diagnosis and follow-up, treatment affects it, and it is a carbon-13 labeled urea issue. Fecal antigen test, of course, available. Acceptability is very easy. Diagnosis and follow-up, it can be used. Treatment affects the fecal antigen. Once you are on treatment, fecal antigen will be negative. Serology you do on the endoscopic material, that is the CAR test can be done. ELISA or IgM, there is no effect of treatment. This is not for follow-up, it's only for diagnosis. Now, you need to know about urea breath test, whether you are not doing or doing. It may be a short notes for you. Urea breath test. How do I do it? Off antibiotics for 4 weeks, off PPIs for 2 weeks, overnight fast. So patient, I want to do UBT, no antibiotics for 4 weeks, and PPIs also stopped for 2 weeks. Overnight fasting is there. C13 labeled urea. Normally urea is C14, carbon 14. We use C13 labeled urea. 1 capsule of 1 milligram of urea is given at 0 time. The patient swallows. After 3 minutes, 20 ml of lukewarm water is given. 10 minutes later, patient takes a deep breath and holds for 10 seconds. No PPI no antibiotics for 4 weeks, no PPI for 2 weeks, overnight fasting, 1 capsule, 1 milligram of C13 labeled urea is given, 0 time, note the time, exactly at the end of 3 minutes, you give 20 ml of water, and after 10 minutes, ask the patient to take a deep breath and hold for 10 seconds. 10 seconds, like that, and then he exhales through a straw the breath into the special balloon. The sample is analyzed for C13. If present, test is positive. What is the basis? If there is a H. pylori, it secretes an enzyme called urease. This urease will split the urea, radio-labeled urea. And once the urease splits the urea, it becomes carbon dioxide. That carbon dioxide contains carbon labeled with C13. That comes into the exhaled breath. That is positive, means there is urease from this. I have given a urea capsule and radio-labeled urea capsule. If there is no H. pylori, there is no urease. H. pylori urea is not destroyed. Urea passes into the lower GI tract. Breath is negative for carbon level. This is the basis. You have to do the urine. It's contraindicated pregnancy because this is containing a radio-labeled material. Pathogenesis of ulcers. There are many, just like any disease, there are aggressive factors and there are defensive factors. There is a tug of war going between the aggressive factors and the defensive factors. Therapy is directed at enhancing the host defense and eliminating the aggressive factors, particularly H. pylori. What are the defensive factors? The mucus, duodenal mucus, bicarbonate layer, the blood flow, cell renewal, prostaglandins, phospholipids, radical scavengers, they are all defensive factors. Aggressive factors, acid, pepsin, bile salt, NSAIDs, H. pylori are the aggressive factors. Between the two, there is a tug of war. Whichever one wins, automatically they will have the upper hand. Now, peptic ulcer, PUD. Lifestyle and medication, H. pylori test has to be done, and then UBT can be done, stool antigen or antibody can be done. And if UBT is not available, you test by the antibody. H. pylori plus eradicative treatment for 2 weeks, plus PPI, full dose PPI for 2 months, and 1 plus 1 more month if required. Stop NSAIDs, decrease the dose, selective drugs can be used, which have got lesser effect on the stomach. Among the NSAIDs, certain drugs like it, they are not dangerous to the gastric mucosa. You can select gastroprotection by using misoprostol. Misoprostol is a drug which is 200 micrograms 4 times a day. This misoprostol is also used as an for termination of pregnancy. Here, when you are having for gastroprotection, you may use misoprostol. Repeat the upper GI endoscopy after 8 weeks. Non-healing ulcers. There are certain causes of non-healing ulcers. So when you come to PUD, peptic ulcer disease, what is the management? Lifestyle and medications. H. pylori must be tested and treated, and eradicative treatment for H. pylori. What is the eradicative treatment for H. pylori? H. pylori should be treated with combination of 3 drugs. What are they? One will be amoxicillin, 1 gram BID in less than 50 kilos. Patient is more than 50 kilos, 2 grams BID, very large dose of amoxicillin. Amoxicillin, 1 to 2 grams BID, plus then you have to have metronidazole, 400 milligrams, 3 times a day, and or you can use other intestinal agents like that. Clarithromycin, 500 milligrams BID. Okay, 2 grams of amoxicillin, 500 milligrams of clarithromycin, 400 milligrams of metroxynitrozole is available as a kit, HP kit, some kit. You'll have morning 3 tablets, evening 3 tablets. Before you have to give them. How long? Minimum of 2 days. And sometimes you may extend for 1 more HP kit. Without there being demonstrated evidence, generally is not given. When you do an endoscope, take the gastric sampling, test for the antigen positive, put them on it. Or test is negative, but there are salt and pepper appearance is there, you can give. And then full dose PPI for 2 months, and then extend it for 1 more month, stop all the NSAIDs, reduce the NSAIDs. So instead of giving non-friendly NSAIDs, you can take the modern NSAIDs, which are more gastric friendly, and if necessary, you can use misoprostol 20 micrograms 4 times a week. Repeat the UGI for this one.